It's a pleasure to introduce Dr. LaCasce. She's associate professor of medicine at Harvard School. She's also the program director and she co-directs the AYA program at Dana-Farber. She's the chair of the Lymphoma Research Foundation, and she's serving the NCCN Lymphoma panel. We look forward to hear from you, Dr.
Thank you so much. It's such a pleasure to be here, and I really appreciate the hospitality. So this talk I'll be focusing on non-Hodgkin lymphoma in adolescent and young adult patients. These are my disclosures. And here's the outline. We'll talk about epidemiology, management, and then late effects, which are really key in this unique patient population. So as you can see here, non-Hodgkin lymphoma is a common disease in adolescent and young adults, particularly in the 15 to 19 range, and becomes less common over time, but still a significant number of cases in these particular age group. And when you look according to the subtype of non-Hodgkin lymphoma, you can see over time there are changes in kids, pediatric patients under the age of 15. We see a lot of Burkitt lymphoma. As you get into the AYA range, 15 to 39, you see decreasing cases of Burkitt, but increasing cases of diffuse large B-cell lymphoma, anaplastic large cell lymphoma, which we've just heard about as a common disease also in this age range. And then when you look at the bottom at primary mediastinal large B-cell lymphoma, this is really a disease almost exclusively seen in the AYA population. And although it is rare, it is a very interesting and important disease. So when we look at the 5-year disease-specific survival for non-Hodgkin lymphoma in AYA patients, you can see in the middle bars the outcomes are really quite good, and in general are significantly better than for patients who are over 40, and not quite as good compared to our pediatric patients. The one exception is for primary mediastinal large B-cell lymphoma, and you can see in the patients who are under the age of 15, the outcomes are inferior, and this has been seen in several different studies. The reasons why this might be true are not clear, but overall the outcomes, particularly for primary mediastinal large B-cell lymphoma, large cell, Burkitt, are all really very favorable in the AYA population. So when we focus in on the diseases that we see in this group, I'm going to lump together diffuse large B-cell lymphoma and Burkitt lymphoma. And when you think about the epidemiology and biology, when you look at Burkitt lymphoma, it accounts for about 50% of the diseases of non-Hodgkin lymphoma in pediatric patients, and much rarer, only 2% in adult populations. There is a male predisposition. And as defined by the disease, this is a germinal center subtype of non-Hodgkin lymphoma with MYC rearrangements. The outcomes in pediatric patients are really excellent at over 90% event-free survival. And in adults, what we see is that outcomes worsen with increasing age, partially due to toxicity, perhaps due to biology. In diffuse large B-cell lymphoma, we don't see as many cases in pediatrics. It again rises as the age of the patient increases. There is a male predominance in both adult and pediatric patients. In the pediatric and AYA setting, the vast majority of the cases are germinal center and subtype, which is different in adults. As adults age, we see more of the activated B-cell subtype. MYC rearrangements are seen in about 10% of adult cases. And the event-free survival in pediatrics, again, is really outstanding at greater than 90%, where about 70% in adults. For primary mediastinal large B-cell lymphoma, again, the pediatric patients tend to do a little bit worse, again, unclear reasons, but for adult patients and the AYA patients, the outcomes are really very favorable. So when we drill down and look at how these patients are managed according to where they are treated, whether they're treated by pediatricians or adults, you can see in the top figure, these are the pediatric regimens. And with diffuse large B-cell lymphoma and Burkitt lymphoma in pediatrics, these patients are treated with identical regimens, very aggressive multi-agent chemotherapy regimens with very good outcomes in excess of 90% for the majority of diseases. Below, you can see the data for adult patients with, on the top, Burkitt lymphoma. And you'll see that the outcomes, the event-free survival is around 70% in most of the multi-agent aggressive chemotherapy regimens, with the exception of dose-adjusted, or EPOC, The study by Kieran Dunleavy had really excellent outcomes with more than 95% event-free survival. However, the patients who were treated in that particular study appeared to be lower risk than what we generally see in adult population, with fewer patients having CNS involvement or bone marrow involvement. So rituximab actually came to pediatrics much later than it did in adult oncology, and you can see this was a randomized study that was just published in 2020 comparing rituximab plus chemotherapy to chemotherapy alone in patients with pediatric aggressive lymphomas. And you can see 164 patients in each group. The majority of the patients were under the age of 15, but about 10% would have fit the AYA classification. Again, the majority of these cases were Burkitt lymphoma, and the staging here is used the St. Jude staging, where Group A is surgically resected, Group C is CNS or marrow involvement, and B is everyone in between. And this study included groups B and C. And you can see more than a 10% improvement in event-free survival with the addition of rituximab, which sort of mirrors what we see in adults, and with a trend to benefit in overall survival. And this finally led to the incorporation of rituximab into the pediatric regimens for aggressive mature B-cell lymphomas. So switching gears to anaplastic large cell lymphoma, which we just heard about in nice detail. The pediatric approach, and I included the table here depicting the regimens used in pediatrics, and this is very similar to what's used in B-cell lymphomas. And you can see really very aggressive multi-agent chemotherapy, including intrathecal therapy, drugs like ifosfamide, a lot of dexamethasone, systemic methotrexate. And in this study, this was a phase 2 study in anaplastic large cell lymphoma, and as noted before, the majority of the pediatric cases are ALK positive with the NPM-ALK rearrangement. And in this study, brentuximab was added to this complex aggressive chemotherapy regimen, and you can see very favorable 2-year event-free survival of about 80%. They also did molecular testing here looking at minimal disseminated disease, and that was predictive of event-free survival. And as you just saw in the Echelon 2 study comparing brentuximab vedotin plus chemotherapy, CHP, in adults with T-cell lymphoma, this is the overall population, and you can see a benefit in progression-free survival of about 48 months with the brentuximab arm compared to 20 months with the chemotherapy arm. And as noted, about 70% of the patients, this study was designed to look at ALCL predominantly, and here about 22% of the patients had ALK-positive disease. And when you look at the forest plots, again, the patients who are most likely to benefit from the addition of brentuximab were those who had ALK-positive anaplastic large cell lymphoma. So in terms of primary mediastinal large B-cell lymphoma in the US, we predominantly treat this disease with dose-adjusted R-EPOCH based on this study published in the New England Journal now back in 2013. This study showed really extremely high event-free survival for patients treated at the NCI. There has always been some criticism of these studies at the NCI with regard to patient selection. If someone has PMBCL and has a tamponade or has SVC syndrome, they're obviously not going to travel to the NCI to participate in a trial. So they included a cohort of consecutively treated patients from Stanford with dose-adjusted R-EPOCH, and you can see the event-free survival in that group was 100%. The real-world data, however, looks a little bit less favorable, and this was in a multi-center retrospective analysis led by Lisa Roth at Cornell. And you can see overall the progression-free survival with PMBCL treated with dose-adjusted R-EPOCH is about 85%. And again, here you can see a suggestion, though not statistically significant, that patients under the age of 21 had a little bit worse event-free survival. And then when you look at the outcomes according to the Deauville score for the end-of-treatment PET scan, it's important to notice here the Deauville 4 patients, you can see here in the red curve, a fair number of those patients do well, and this is something that we notice in treating these patients. At the end of treatment, PET scan often has residual uptake, usually low level, with continued decrease in the size of the primary mass. And many of these patients actually do not have residual disease, and we typically would follow with serial PET imaging or perhaps a biopsy if there was a concern. And it's really only the patients with Deauville 5 who do poorly with this disease. The other unique feature of PMBCL is that the recurrences occur very early. You can see mostly within the first year. And then after the 18-month mark or so, it's very, very unusual to see a recurrence of PMBCL. So we've learned a lot about the biology of PMBCL over the past decade or so, with the recognition that it shares many molecular features with classic Hodgkin lymphoma, including copy gains and amplification of chromosome 9p24, which encodes for PDL1. And PDL2 is shown here, making this a disease very attractive to treat with a checkpoint inhibitor. And this was the update of a single-arm pembrolizumab study in the relapse and refractory setting, published in 2023 by Zinzani. The overall response rate for pembrolizumab was 40%, with about 20% of patients achieving a complete remission. You can see the progression-free survival is short at 4 months for the entire group. But for those patients who achieved a complete remission, the duration of remission actually looks very favorable without any significant number of relapses following at the 2-year mark. So this has led to a study in the US, a collaboration between the Children's Oncology Group and the US Adult Cooperative Groups, asking the question, if we incorporate PD-1 inhibitors with dose-adjusted R-EPOCH or standard upfront therapy, can we improve outcomes in primary mediastinal large B-cell lymphoma? This is a very complicated diagram here, but we anticipate that the vast majority of patients will be getting dose-adjusted R-EPOCH. The study was meant to be very inclusive for providers who wanted to give R-CHOP plus radiation, which is sometimes used, though I think most of us try to avoid radiation in this young patient population. This study was designed as a phase 2 with a rollover to a phase 3 if the accrual was good, and surprisingly, this study has accrued incredibly well, and we will probably finish the accrual in the next year, and it'll be really interesting to see whether the addition of nivolumab leads to better outcomes. The one concern is that these patients are getting prednisone with their dose-adjusted R-EPOCH, and whether that will have any implication for the efficacy of the checkpoint inhibitor is unclear. So moving on to late effects and survivorship, I think this is really a key consideration when thinking about our adolescent and young adult patients. And this was a recently published analysis from the Netherlands looking at outcomes of patients with aggressive B and T cell lymphoma over the decades according to age. And you can see in the top right with the Burkitt lymphoma patients, the outcomes in the younger group have been very good all along, but are improving in the patients who are 18 to 40 over the decades, likely due to the incorporation of rituximab. Diffuse large B-cell lymphoma, if you look here at the 2010 to 2015, these outcomes are really quite extraordinary for patients up to the age of 39 receiving Rituxan-containing chemotherapy. And again, we see significant improvements here in patients with ALCL, likely due to the introduction of brentuximab vedotin in the ALK-positive group, which predominates in this age range. So this is a large analysis from the Childhood Cancer Study Survivor Program, which looks at early adolescent and young adult survivors of malignancies over 5,800 patients, with about 35% of the patients having Hodgkin lymphoma and 10% having non-Hodgkin lymphoma. And you can see a significant increase in mortality beyond what you would expect in age-matched controls. And if you look at the AYA group here, starting at the age of 20, the cumulative mortality rate by the time you get to 45 is about 20%. Likely much of this is driven by radiotherapy. which is also highlighted in this analysis, looking at the absolute excess incidence and mortality of second cancers in adolescent and young adult survivors of more than 5 years from their original diagnosis. And here in the non-Hodgkin lymphoma, you can see the increase in second cancers, both in incidence and mortality over time. Though if you compare this to Hodgkin lymphoma, it's less pronounced. And in Hodgkin lymphoma, you can see really the highest risk is in females at 30 or plus years of age, likely again related to the use of mediastinal radiation and likely breast cancer. So what about anthracyclines? I think this is an issue that our pediatric colleagues worry a lot about, and I think on the adult side, we seem to be a little bit less worried about this. And I think this stems from the early studies in ALL, where the increasing doses of anthracyclines were used, resulting in very high rates of cardiotoxicity with those initial studies. For a long time, it wasn't clear exactly how anthracyclines exert a negative effect on the cardiac myocytes. As you know, doxorubicin and anthracyclines work by binding to topo-2 alpha and block DNA replication, causing cell death in the cancer cells. In terms of the cardiomyocytes, it's felt that the anthracycline binds to topo-2 beta, and this causes reactive oxygen species to be released, causing damage to the cardiac myocytes. Dexrazoxane, which has been used in pediatrics now for many years, is thought, it used to be thought to be an iron chelator. It's now thought that this probably binds to topo-2 beta and then exerts its cardioprotective effect in that manner. So there are a number of risks associated with anthracyclines, and we know the cumulative dose over 250 milligrams per meter squared in the AYA population is probably is lower than what we think about in the adult patients, where we think about 400 or 450 cumulative dose. It does appear that by giving a longer infusion that this may be protective. Obviously, giving radiotherapy in combination with anthracyclines is associated with significantly increased risk of multiple cardiac subsequent late effects. Younger patients and elderly patients seem to be most susceptible to anthracycline-mediated cardiotoxicity. And there does appear to be genetic factors, polymorphisms in certain genes have been associated with an increased risk of the subsequent development of anthracycline-mediated cardiotoxicity, which increases in incidence over time the further the patient gets out from the receipt of therapy. Fertility issues are obviously a major concern in our AYA patients, and this was a large retrospective analysis of various chemotherapy regimens published in 2019, and you can see here the risk was separated into low, intermediate, and high risk. For Hodgkin lymphoma and non-Hodgkin lymphoma with ABVD and CHOP, the rates of infertility are very low, fortunately, though for patients who develop recurrent disease and require stem cell transplant, obviously the rates are very high. Oftentimes in studies, FSH is looked at as a marker of fertility, which really is not all that helpful. We use the AMH level, the anti-Mullerian hormone level, which really is a much better indicator of ovarian reserve. We'll often get this at baseline before we start treating, particularly in our AYA female patients, and then after therapy, recheck it at a year. We send a lot of patients for reproductive endocrine consultation. Many of our patients need to initiate therapy rapidly, and we don't do fertility preservation in a lot of these patients because we will have time later. We use Lupron based on data from particularly the breast cancer literature, which may provide ovarian protection. The one issue to consider is as these patients get older, to refer them early for fertility, again, reassessing their fertility, because as they get to the later 30s, their fertility is likely to diminish, and we don't really understand the impact of regimens like dose-adjusted REPOC and even RCHOP.
1 minute.
All right, survivorship issues, these are really key. These are from the NCCN. and list a number of different areas to think about, particularly radiation-associated effects and anthracycline-associated effects. This is a nice resource. And then multidisciplinary care obviously is incredibly important in this group of patients, including psychosocial issues, financial counseling. You know, this is a very, this group of patients has a lot of needs. They're just coming into their own and starting their lives as independent adults. So involving navigators, nurses, all of these specialists is very important. So in summary, lymphomas in AYA, non-Hodgkin lymphoma in adolescent and young adult patients has a number of unique features, including biology. Therapeutic approaches differ between the pediatric and adult approaches, but I think over the past couple of years, we've really seen the groups in the US come together to try to do cooperative studies to really improve outcomes in these patients. Again, looking at survivorship issues and access to care. So with that, thank you very much.